I'd like to next introduce Dr. Mark Likerovich Fournier, who will be presenting on OAT Safer Prescribing today. Mark completed his postgraduate training in Winnipeg, where he subsequently practiced mostly in acute care until 2015, when he applied for a methadone license and started working in addiction medicine. Following this, Mark worked as a hospitalist and in addiction medicine in Nanaimo and Central Okanagan. Currently, Mark is working with AVI Nanaimo on Vancouver Island as a physician and medical director, supporting a multidisciplinary clinic with a primary focus in supporting people at risk for HIV, HCV, and polysubstance use disorder. They're currently in the process of organizing an enhanced harm reduction program. Welcome, Mark, and I will turn it over to you. I can share your slides, so just let me know when you want me to advance them.
Okay, thank you, Angie. Hi, everyone. As Angie said, my name's Mark Likerovich Fournier. Most of my patients call me Dr. Mark because it's easier for them. I was previously working at the Vernon Methadone, at the Vernon MHSU Oat Clinic, and just recently transitioned over to Vancouver Island, or back to Vancouver Island, where I came from a couple of years ago. So move on to the next. So I want to talk today about harm reduction, safe supply. These two terms are kind of interchangeable, depending on what lens or what approach. If you look at it mostly from an OAT or a treatment lens, then people talk about harm or safe supply. If you look at it from a harm reduction lens, then this style of prescribing, mostly harm reduction, because the goal is to reduce the harm caused by the illicit drug supply. Next slide, please. So I'm coming to you from Nanaimo, so I want to acknowledge that I'm on the traditional territories of the Coast Salish people, including the traditional territories of the Snuneymuxw and Snohomish First Nations. Next, please. I don't have any disclosures, and I actually didn't find out until yesterday that I'm getting some remuneration for this. I have no affiliations, and I don't receive any money from anybody for anything else. Next, please. So looking at the harm reduction, I put two different definitions up here. The first sort of official one that we find in the SUAP, or the Government of Canada Substance Use and Addiction Programs, refers to policies, programs, and practices aimed at reducing the harm associated with the use of psychoactive drugs in people who are incapable of stopping for whatever reason. The sort of alternate definition would say that it's an evidence-based, sort of client-centered approach, looking at reducing the harms and supporting people where they're at. And when I hear that term often, supporting people where they're at, and to me, looking at people where they're at is, what's their past, what's their history, how are they doing, what is it that drives their addiction. There's a number of variety of reasons why people use. Sometimes there's mental health that's driving the addiction. Sometimes it's addiction driving mental health. It could be early exposure at an early age. Prescription drugs we're often our physicians' prescribing patterns have often been associated or linked or blamed for our current opioid crisis. Don't necessarily always agree with that, but we can talk about that in a bit. Next slide, please. And the most important thing sort of in my practice, when I look at somebody, as I was just saying, I'm looking at seeing where they're coming from, what their goals are, how can we help them, how can we support them, and not only just with the replacement medications, but with the team, and that was one of the advantages of working with the Vernon Oat Clinic, is that there's a team of people supporting the prescribing that, no, so I guess the prescribing supports the team, and the team also then supports the prescribing, because replacing drugs alone is not the answer, not the only answer. And offering social supports and social assistance and housing, although important, is also not going to work on its own. It's also important to treat people with dignity, and respect. Doesn't matter where you come from, doesn't matter what you look like, it doesn't matter if you haven't had a shower in days. We should still, everybody has the right to be treated the same and with respect. And I also believe that it's important in involving patients in their choice of medications. Traditionally, our program has been physician or prescriber driven, where somebody comes in, we offer them oats. Used to be methadone only, then we added Suboxone, now we've added Cadian. The pandemic has helped us add other medications in order to support, in order to support people. But that's always primarily from a sort of medical model. There's seems to be more people who are looking at a harm reduction approach. What can I do to reduce the harm? And that there's a when I look at programs like the Safer program in Victoria, the Safer program in Vancouver, and their approach to their patient population, asking people what they need. There were a couple of studies where they looked at people who use drugs who are either actively using or in recovery, and what would they benefit? How could we support them? How could we help them? And one of the common sort of themes was that people were never given a choice in the early days of sort of treatment. Is they were offered methadone and that was it. The program was often very punitive, whereas from a harm reduction lens, we're looking at involving patients in their discussion, in their care, and offering them a choice of medications, not just oat, and with the harm reduction not necessarily tied to oat. And of course, that's all in a non-judgmental atmosphere environment. Next slide, please. So the medications that we commonly see, or that I commonly use, they're not all listed here. The hydromorphone or dilaudid is probably the most common one used in harm reduction. It's the one that the BC-CSU recommends primarily. It is not adequately replacing the effect of the fentanyl. A lot of people can be on fairly high dose dilaudid and are still using fentanyl. They still come in testing positive for fentanyl. They still have a lot of cravings. Because it's not an equivalent replacement. I don't have the fentanyl patch up here, but that's something that seems to be becoming a little bit more prominent. And then in discussions with patients, I often get requests for oxys. And the biggest difference, or one of the reasons driving the request for oxy, is that apart from their street value, is that they are easier to crush, to snort, and to inject. A lot of people are injecting their fentanyl, and when we offer them dillies, it's not the same. If you're injecting primarily, then we need to replace it with something where you're injecting and not necessarily an oral medication. And so I do prescribe oxys. I know it's not a very popular, it's not on the list of the BC-CSU guidelines. However, it is in the SUAP documents, where they do recognize that people want to continue injection and they want to replace the drug that we're offering them, the drug that they're using, with something somewhat equivalent. The grays are the street name for Amicelon 100s. As you can see, they are a gray and white capsule. It's also one that is frequently crushed and injected. What I find mostly are patients who were using heroin before the days of the fentanyl are much more interested in having grays than in having either dilaudid or oxy. And as I mentioned, I don't have the fentanyl patch on there. That's a program that we're going to be working at setting up here in Nanaimo. It's just kicking off in Vernon. There's a fentanyl patch program in Kelowna, Vancouver, Victoria, and all of them have been highly successful. Some of the team here had an opportunity to visit one of the programs in Vancouver, and they're using fentanyl powder in capsules on a PRN basis. They've had great success with that approach, and patients like it. They feel that it manages their cravings and their withdrawal better than any other options that we've offered them so far. And then for stimulant use disorder, although there isn't a lot of evidence to support the use of stimulants, dexedrine and Ritalin are the two that are commonly used. I will usually start somebody on 4 capsules, either the 10 milligram or the 15 milligram capsules, daily dispensed, and then adjust based on patient feedback. My experience has been that if we're open and transparent with the patients, then generally, I get fairly reliable feedback from the patients. I'm also in close communications with the pharmacists in our community who are dispensing, and I rely on their feedback on patient behavior, on what they're like when they show up in the at the pharmacy to pick up their medication. Have they noticed a change in the patients and their behaviors? And we have had some positive responses in Vernon with some of the patients who are heavy stimulant users who did well with the dexedrine and Ritalin. And I've also had times where it went terribly wrong and psychosis was worse, and it just did the one patient more of a disservice. But that's always a risk, and sort of in my perspective, or my opinion, I think that it's a risk worth taking if we can help 1 or 2 people cut down, as long as we're monitoring those patients closely and we catch it early enough and we stop the stimulants, then we can usually reverse the effect of the stimulants. The benzodiazepine is probably one of the most controversial replacement drugs at this time. As everyone knows, the drug supply is heavily contaminated with benzodiazepines. More and more often, I see benzodiazepines on the urine drug screens in patients who are not actively seeking out benzodiazepines. Although I haven't seen any withdrawal seizures myself, I've had reports from some of the physicians, either working in the community or working in some of the hospitals. Witness or have patients have they've seen benzodiazepine withdrawal. I've started co-prescribing benzo and OAT or other opiate in an attempt to mitigate the withdrawal. Again, I think I've had more successful results or responses in co-prescribing benzos than I've had failures. relying primarily on patient feedback. The one that I use preferentially is Clonazepam, and the reason for the Clonazepam is that it doesn't typically show up on the urine drug screen. And so if I'm prescribing, the problem is then it's hard to say if they're taking it, but if I see that there's less benzo or less frequent benzodiazepine on the UDS, then it would suggest that the Clonazepam is helping. I've also started benzo replacement in patients who are on high dose OAT, high dose harm reduction, and we're still using because they were still experiencing withdrawal, and come back and say that, I have one hoot, one dragon, and I feel much better. That's usually, it seems to be more related or tied to the benzodiazepine and the drugs than the sort of not giving them enough oats. And there was a question that popped up about modafinil and in cocaine. I haven't had a lot of people with cocaine, primarily cocaine use disorder, mostly because we work in out of an OAT clinic, and we haven't been targeting the population who use primarily stimulants. That's something that we're hoping to expand here in Nanaimo once we have our enhanced harm reduction program up and running, is to see if we can't reach the population who are using primarily stimulants. Next slide, please. So from my perspective, I think harm reduction is primarily involving patients in a shared care decision, getting feedback from patients on what are they looking for, what are they hoping to get out of their treatment, how can I support them, how can the clinic as a whole support them, what are their goals, and offering them choices. And with trying different medications, because we start one, and if one fails, it doesn't necessarily exclude the other one. I'm not, I don't try and direct their care so much as, I try not to medicalize their treatment as much as involving them in their shared care. And really the goal is to try and keep people from dying. Something else I was going to say and I totally forgot. I guess that's it for now. Are there any, if there was another question that had popped up and I missed it. Oh, what dose of clonazepam? So clonazepam depends on the patients. I usually will start with 1 to 1.5 milligrams twice a day and then titrate from there. I've tried lower doses and I haven't found that, less than 1.5 twice a day is helpful. I've gone as high as 6 milligrams twice a day. And once patients were stable, started tapering from there.
Thanks so much, Mark. Do we have any other questions from the group for Mark?
Yeah, I was wondering about how long a taper are you doing? I'm typically doing like super long tapers, but I'm just wondering what your typical pattern is.
So for the benzodiazepine, it depends mostly on how long patients have been using. If they've been using, I've been fortunate that I've had patients come in, they've been using for 1 or 2 years. And we were able to taper the benzodiazepine fairly fast over a matter of couple of months. And others, well-entrenched addiction, who are using a half ball or a ball a day. And for them, typically, I usually do a much slower and taper down their benzodiazepine sort of over months.
Thanks, Mark. I see Hanky has his hand up. Hanky, did you have a comment or question?
Yeah, I was just wondering what your thoughts on being like hydromorphone just becoming the next treatment modality for OAT. Like, I mean, people were hesitant prescribing Cadian, and now, I mean, Cadian is probably very mainstream, and then true safer supply just becoming like powdered fentanyl, what they're anyway using to prevent that.
Yeah, hydromorphone alone, I haven't had a whole lot of luck with hydromorphone alone. People on the street don't like it. It's not, it's similar to heroin, but it's not close to the fentanyl, and it just doesn't replace it. And we've had people on really high dose. We had one patient, particular index patient in Vernon, where he was taking 35 hydromorphone a time, twice a day witness, and he was still using fentanyl, and it just wasn't working. Switched over to Oxy, and now he's on a combination of Oxy IR and sustained release, and seems to be doing much better. Right. So we're not replacing, the hydromorphone doesn't give that euphoric effect. And that's what I think, that's what people are looking for. That's what they want. And if we're going to replace something, I think we need to look at replacing, looking at the reason why people are using and targeting the reasons and what's driving them if we want to have any success.
Cole, did you have a question?
Yeah, thanks for the presentation, Mark. I'm curious as to your breakdown in terms of what percentage of your clients on OAT are also getting safe supply, how many are just getting safe supply alone, and then wondering if you have any advice on how you bring up all of the options, like when that happens, how you offer it, when you think of it.
So whenever any new intake, the discussion is always the three different accepted OAT medications, methadone, Suboxone, and Cadian. And I almost always start people on safe supply, either as a bridge to achieving a therapeutic dose of an OAT, or as an alternative, and looking at getting to a lower dose of OAT, as opposed to having a super therapeutic or super high dose of methadone with all of its side effects, or Cadian with the severe constipation. A combination of both seems to work better. Also, when people use drugs, they don't take it once a day. They're using it multiple times throughout the day. So having that ability to be able to take a few pills in whatever fashion, whether they, swallow them whole, chew them, crush them, snort them, or shoot them, that helps to replace the habit, because using drugs is also about habit, not just about the drugs themselves. So the breakdown, to answer your question, then the breakdown, I'd say probably about 80% of my patients are on combination OAT and harm reduction. When it's time to start tapering, usually, it's a conversation I bring up with the patients at every visit, but I usually leave it as more of a patient-driven, and more frequently now, as this has been going on for a longer period of time, I'm seeing patients who've been on it for a year or sometimes longer, who are coming in and saying, okay, like, I'm done with the dillies, I want to start tapering off, or I'm done with some of the other harm reduction, I want to start tapering down on some of these other medications. I don't have a set timeline or template that I use. I individualize treatment to each patient. And I'm sorry, did I answer all of your questions?
Yeah, sorry I included so much there. I saw Trail is asking, what doses of hydromorphone are you using?
The BC-CfE guidelines suggest up to 14, but I have a lot of patients on higher doses than that. It's not a Jen smiling, because yes. It's I look at it more so from a harm reduction lens. I understand and appreciate that diversion is always an issue, and it's a conversation that I have with patients regularly if there are reports of diversion either from pharmacists or other patients. And it's interesting that other patients are quick to rat each other out. I'll bring that up, and then if it's an ongoing issue, multiple reports, then we'll start tapering off of the hydromorphone or other safe supply. And then if they destabilize, so if I notice that there's a change in their attendance to either the clinic or increasing frequency of missed doses, then we'll bring them in and we'll have another discussion again around the harm reduction and how we can support them. And I always try and reaffirm that the harm reduction is intended for them and not for somebody else. But having said that, no, some of the harm reduction and speaking with others at harm reduction, even if they are diverting their hydromorphone or their oxy or others, if they're spending less time on the street and they're turning less tricks, or they're stealing less, then we can consider that as a positive, as opposed to just looking at some of the other things that we generally look as a positive response.
Thanks so much, Mark, for your presentation. I want to ask if there's any last questions from the group before we move along. Yeah, Arlene?
Yes, I have a quick question. First of all, thank you very much. This was so informative. I'm wondering what percentage of your patients are not street entrenched? How many people come in and see you who are still able to perform working functions and living functions?
Very low. I don't have, I don't have the breakdown or the percentage, but generally speaking, the majority of the patients that we were following in Vernon and most of what I see here in the NIMO are street entrenched, homeless, or living in squalor, paying outrageous amounts of money for a dump, rat and cockroach infested apartments or rooms in a rooming house. So it's housing, it's everything that we do now is sometimes I feel like is meaningless if we can't provide housing, because being housed is key to stability. And some days I feel like I'm just supporting people from day to day, helping them, keeping them from dying from day to day, in the hopes that eventually we'll be able to get them socially stable and housed.
Thank you.
Jennifer, did you have a question? I see your hand raised there.
To add to Mark's comments there, and Arlene's question, over the 2 years that we've been supporting this really kind of complex client group, we have seen some stability, people being able to maintain shelter because of engaging with our clinic. So we've seen some social stability. So I think that kind of speaks a little bit maybe to Arlene's question is, are we seeing some of those benefits related to clients engaging with our clinic and being supported by Mark's prescribing practices? And I think the answer is yes. Some people more so than others, but we've definitely seen success in clients. Again, housing is just an ongoing issue to be able to get access to housing, but those that have been engaging and stabilizing in their substance use are more likely to be housed or sheltered within our community.
Thanks, Jennifer. Any last questions or comments before we move along?
Yeah, I'm just sort of reflecting on what our, I can't remember who was asking about housing and stability, and we're looking at it as a long game here, right? So really trying to keep people alive right now, and I will echo the, people having stable housing is key, but even just to be able to, maintain a place at the shelter on an ongoing basis is key, and continuing to connect with healthcare. And then, I continue to have hope because I have clients that who engage with our program who've had 30 years now under their belt of sobriety, and they never imagined that they would leave the life that they were in. So it's a mixed bag, and really it's about right now in the toxic drug crisis is keeping people alive is kind of what we're looking at here.
Thank you. Okay, so I think we will move along. Thanks again, Mark, so much for your presentation. Feel free to stay on the session today or hop off if you need to. I will just pull my slides back up here again.
Unfortunately, I'm going to have to go. Thank you for having me. It's been a pleasure, and it's been a pleasure working with the team in Vernon.
Thanks, Mark.
Thanks, Mark.